So first step in the management, we are switching gears. What do we do now that we know the prevalence, we know how to recognize these patients, and now what do we do about these patients? So we know these patients come with risk factors, and managing the risk factors is part and parcel of how we manage these patients. So recognizing their general lifestyle, dietary, how are they currently eating, what are their exercise patterns, alcohol intake, what weight loss recommendations we could give. We have medically supervised weight loss clinic. We work very closely. So referring, using their expertise. Now they are very empowered with availability of Wegovy, Zepbound, and me just focusing on the liver without necessarily addressing the person as an individual that has other risk factors. It's become a multidisciplinary sort of management. We still have bariatric surgery too, in those where they may walk in and say, I've tried all these weight loss drugs. I'm done with it. I have obesity in the family. I would like to pursue bariatric surgery. Yes, of course, we're going to look into that too. So as I said, if you have MASLD, low risk for fibrosis, you want to address the other risk factors, and at least even if you don't have the capacity to address, you put the patient in the right path with medically supervised weight loss clinic, bariatric surgery referral, or other nutritional clinic or whatever options you have. But as they advance fibrosis, then you want to make sure that you address liver-directed options too, in addition. So oftentimes we are faced with the question, what do I do, doc? What can I do with regard to my lifestyle? And often the questions are, what kind of food can I eat? Do they even have an understanding of ultra-processed food and drinks? How do they contribute to MASLD? And what can they do? So, this is I think the British version. I'm not a big fan of why they put the lamb and the pork there, but we often suggest keto diet and Atkins diet in those who are primarily on ultra processed foods. But this is some basic food groups. Some are increasingly are associated with MASLD, particularly sodas and processed foods. As you see, the cereals, anything that has multiple ingredients listed, color number 45. I don't know. I like it, but I'm not sure what that is. But so you have to be careful. How much is it processed? How much is it, starting from scratch? So do diets affect MASLD? Yes. The patients who pursued a diet, here is the Mediterranean diet versus no intervention, the liver stiffness improved, fatty liver index improved, HOMA-IR improved. Obviously, whether it is the diet or calorie restriction or type of foods in the diet, or what if somebody just doesn't like Mediterranean diet, he's not going to eat much. So whatever it is, the quality of food is much better with regard to Mediterranean diet. Now, we do suggest intermittent fasting. There are different types of fasting, alternate day fasting, the 5-2 diet, 2 days of the week you fast, then the time restricted, most commonly is the 16-8. I am a big fan of 16-8, and Lindsay and I kind of talk about it with the patients. 16-8 is 16 hours of fasting, 8 hours of unrestricted eating. But after you're on this diet for certain time, the stomach shrinks, so you can't eat as much. 16 hours includes your sleep time. You can drink coffee, tea, some hot water, lemon, and some honey. Anything that is below 50 calories doesn't bring you out of the ketosis. So 6, 7, 8 hours of sleep and 3, 4 hours of coffee and some water, you can get to 16 pretty easy. And after a while, it gets a habit. Most of our peers do that, I know for sure. So with this kind of intermittent fasting, liver steatosis and liver stiffness improve. Ultra-processed food diets causes excess calorie intake and weight gain. So what happens, sometimes patients ask me, well, I changed from regular soda to diet soda. How am I doing? So what happens is in these kind of ultra-processed foods, the gut microbiome, even though you are cutting down the calories, the gut microbiome is not it's still in favor. So you may end up becoming more hungry and look for calories in some other way. So that's the reason why I am not even fan of the diet Coke or diet Sprite. I just recommend that they avoid all sorts of ultra-processed foods. So there are recommendations with regard to exercise too. Aerobic exercise versus resistance training. We are big into emphasizing resistance training. Most obese MASLD patients, whether they have cirrhosis or not, are sarcopenic, which means loss of muscle mass. And therefore, we emphasize on resistance training, trying to retain as much muscle as possible. This is particularly important for cirrhosis patients. And those, imagine a cirrhosis patient who's already sarcopenic and obese and goes to medically supervised weight loss clinic and loses 30, 40 pounds. So on an average, you lose 1 pound for every 1 pound of muscle for every 4 to 5 pounds of fat. So that is very, very precarious for somebody who has cirrhosis, already has less muscle mass and losing more muscle mass. And that might put somebody in hepatic encephalopathy because the muscle is ammonia sink, and losing muscle mass can put a patient with cirrhosis at a risk of developing hepatic encephalopathy. So we are very, very strong in emphasizing Pilates, dumbbells, bands, stretching bands. Even if they can't afford anything, just lift grocery bag or lift soup can. And if you can't move, just sit in the chair and lift the leg against gravity. Or we would prefer walking the stairs rather than walking with the dog, just to make sure that they are doing resistance training. Lifestyle recommendations, yes, many of us have used this.